Hi, my name is Lilian Palma. I'm a pediatric nephrologist in Brazil, and I'm here today having this honor and pleasure to share with you a little bit of the challenges in the differential diagnosis of atypical hemolytic uremic syndrome, which I will call AHUS for short. I have been a consultant for TMA for the last decade here in Brazil, and more recently jumping into another complement disease in the kidney that is C3 glomerulopathy. But where do we start? We start with this syndrome called thrombotic microangiopathy. One has to recognize this syndrome on the bedside, and it is composed by a triad of microangiopathic hemolytic anemia, low platelet count, and organ injury. Usually the kidneys are involved. When you have this triad, you should be able to make the diagnosis of TMA and understand that this is a severe condition. This patient needs a lot of attention. The challenge here is to define what is the underlying cause of the TMA, because there are plenty of diseases with very different pathophysiologies that can lead to the same presentation. And what I'm going through today with you for the next 30 minutes is how to make this quick suspicion to make the correct management. The first and most important cause that one has to rule out, because it's a true medical emergency, is thrombotic thrombocytopenic purpura, or TTP, which is the severe deficiency of this enzyme called ADAMTS13. Where does this enzyme act? It acts on the von Willebrand factor that is on the endothelial cell. Usually it is flipped, but when there is shear stress, it unfolds and becomes an anchor for platelets in order to stop a bleeding. The enzyme ADAMTS13 then comes into its role and cleaves these huge multimers of von Willebrand factor and stops the platelet adhesion. Therefore, you don't have a clot. When there is a severe deficiency of this enzyme, every time this huge molecule unfolds, what happens is that it will trap platelets. And once there is a trapping of platelets, you will have a severe thrombocytopenia, you will have a clot, and this patient will present with organ injury. Usually, the brains are involved. So TTP is a severe disease that has to be promptly recognized, because it has to be treated with plasma exchange or plasma infusion in the first 4 to 6 hours after suspicion. Not every place is planned and programmed to collect ADAMTS13 activity. It's not so easy. You need to centrifuge, citrate tube, and sometimes you don't have it available. So there is a rule on the bedside that now has grown a little bit into what we call the plasmic score, but one can use it in order to check what is the chance of this patient to have a TTP. Mainly taking into account the platelet count, hemolysis, in the absence of malignancy or transplantation, with a smaller MCV, no coagulation disorders, and also mild kidney injury. As a rule of thumb, what I say on the bedside, if you have platelet count less than 30,000, together with a mild kidney involvement in a patient that is severely ill, especially if there is neurological involvement, there is a huge chance of being TTP. If you have ADAMTS13 to collect, okay. If you don't, start immediate plasma exchange. And if you don't have plasma exchange, you start plasma infusions. This can save the life of the patient. More recently, there is a monoclonal antibody called caplacizumab, where it is available. It has proven to be non-inferior to plasma exchange. In children, the most important cause of TMA, and we have seen this in the previous lecture, so I'll go through this more quickly, is the shigatoxin, is what we call typical HUS, or shigatoxin or STEC HUS. What happens is that the shigatoxin attaches to the endothelial cell, especially in the kidney, through a receptor called GB3. This cell will go into apoptosis, and because of the apoptosis, there will be the formation of a clot. The formation of a clot will drag the platelets and adhere platelets and also destroy the red blood cells mechanically, therefore generating the microangiopathic hemolytic anemia with schistocytes on peripheral smear, low haptoglobin, elevated lactic dehydrogenase, and also organ injury. Most commonly, the kidney is severely involved. This is the natural history of patients with STEC. Usually there is the ingestion of the contaminated food. A couple of days later, there is diarrhea. Some patients progress to bloody diarrhea, and only 15% of the patients will develop AHUS or HUS or STEC. What we need to understand is usually when the kid presents with paleness, feeling ill, not urinating, and you have a high suspicion of STEC HUS, sometimes it has passed more than 10 days from the beginning of the diarrhea. And when this kid arrives, usually there is no diarrhea anymore. This is very important for us to understand because the gold standard for the diagnosis is to show the presence of the Shiga toxin, either through blood culture for some kind of strains of bacteria that produce Shiga toxin, or the detection of Shiga toxin itself by PCR. So my advice always for the residents is if this patient arrives and the kid does not have diarrhea, you collect an anal swab or a rectal swab or maybe some aspirate of a little bit of stools and send it to diagnosis, because it will make a huge difference, especially if the patient does not evolve as we expect. What do we expect in STEC? A full recovery in 70% of patients. Some patients will have kidney sequela, and these patients have to be followed closely for hypertension and proteinuria. And some patients, although a smaller percentage of patients, may evolve with some kind of neurologic sequela. So these patients have to be followed closely. And what are the US guidelines today? And that I strongly advise for everybody. Plating stools from patients with acute community-acquired diarrhea on a selective median, and, if possible, perform an assay that detects the Shiga toxins or the genes that encode these toxins in order to make the correct diagnosis and in order also to communicate with health authorities. But when do we think that STEC is less possible or probable or plausible? When the stool culture or PCR for Shiga toxin is negative, especially if you collect this in that window that I showed you of the diarrhea. One of the causes of negative PCR may be that it took too long for you to collect, more than 10, 12 days after the diarrhea started. The other cause of low positivity of Shiga toxin is also the use of antibiotics. When one has persistent thrombocytopenia or the platelet count fluctuates a lot, or arterial hypertension of difficult management, recurrent hemolysis, or in a kidney injury that persists more than 4 weeks, we have to think that maybe there is something different going on there. Maybe we don't have a patient with STEC. And what would be that diagnosis? The first thing that we have to bear in mind is that it may be atypical HUS. And this is very important for us to understand that through a completely different mechanism, you will have endothelial lesion. And this is due to an imbalance in the alternative complement pathway. In blue, we can see the activation proteins which will form the membrane attack complex. And in colorful, we can see both in blood and in the endothelial cell, the counter-regulatory proteins that make this alternative pathway stay in balance. It only gets amplified once you have the invasion of bacteria or other pathogens. Once you get rid of the bacteria, it comes back to normal through the counter-regulatory proteins. The problem is that if you have a genetic defect or an autoantibody, or if there is any other mechanism that breaks the balance of the alternative complement pathway, you will end up with a massive formation of the membrane attack complex that will destroy and deposit on the endothelial cell, leading this endothelial cell to apoptosis or to stopping of its metabolism. This will expose the matrix, and as a response, there will be a formation of a microthrombi, which usually happens in the kidney, but can happen in any organ. When you have this microthrombus, there is platelet attachment, red blood cell destruction mechanically. Here are the schistocytes that we can see in the peripheral smear, and you will have injury to the organ which is supplied by this little vessel. And this is happening through a completely different mechanism. And why is it important for us to think AHUS? Because there is target therapy. Today we have monoclonal antibodies that bind strongly to C5, and they prevent the formation of this huge amount of membrane attack complex, providing the proximal complement pathway working, because this is very important for opsonization of some bacteria. What is important to know is that once you block the formation of membrane attack complex, you need to vaccinate and prevent meningococcal infection. Which are these monoclonal antibodies? The first one was eculizumab, that was approved in 2011 by the FDA, followed more recently by ravulizumab. What is the difference between them? Ravulizumab had a change of 4 amino acids, and this was enough to make it undergo a lysosomal recycling, and the half-life of eculizumab, that is 11 hours, has moved to 51 hours in ravulizumab, which means that you can have the infusion in a very longer period, up to 8 weeks in small children, which facilitates the posology and the logistics of giving this medication. We know from pivotal trials that the earlier you use complement blockade, so the earlier you think AHUS, the better, especially for the kidney recovery. Nevertheless, it's very important for us to understand that even if you use late, we have seen patients that have recovered the kidney significantly despite using it in a longer period, because it's not easy to come to the diagnosis, because there is no gold standard test for atypical HUS. For a long time, we thought it could be genetics, the answer for everything. Now we know it's not. So here we have the genetic background for AHUS, and I put here all the cohorts that were published in the world. And we can see that there is a huge variation from as low as 18% positivity in India to as high as 80% in Japan. It's very important to acknowledge that there is still no uniform standardization of genetics in AHUS. So each center uses its own panel and its own method to see if there is positive or negative. Positivity and negativity has been standardized by the American College of Medical Genetics and Genomics. So you have a grading from pathogenic to benign, and in the middle you have the variants of unknown significance, and this has been applied by most panels and most laboratories. But the genes encoded in each panel is up to each lab. And I think there is a call for action here to have some kind of standardization of genetics in atypical HUS. But so far it was difficult because we didn't have anything of a background in Latin America. And then this month there was a publication of the first Brazilian AHUS registry. And the basic characteristics were analyzed, showing that children had more severe hemolysis, and overall the whole group, there was a 66% positivity in genetics, especially with factor H, which is the most common, and also huge deletions from the proteins related to factor H1 and 3. This is aligned with the global registry, in which 60% of the patients had positive findings. But what of the other 40%? The other 40% of patients who don't have a genetic background still have an unknown mechanism that must be evaluated. In our pediatric group, in a small cohort here in Brazil, we found that most of the patients indeed had genetic findings in complement genes, also in coagulation genes, that today we question if this is pathogenic or not. But it is important to know here some new findings that are very important in children. And I want to call attention. We saw one patient who had a mutation in a gene called diacylglycerol-kinase epsilon, or DGKE. This was a patient who was diagnosed at 17-year-old. He had had 3 episodes of TMA, but the first one started at 6 months. In 2016, he underwent a biopsy. There was a full-blown C3 with microthrombi, a lot of vessel thickening here, and he started eculizumab. Nevertheless, 2 years later, he underwent a rebiopsy because he was still hypertensive. His kidney was not improving, and we can see here that there is chronicity, especially in the vessels with this onion-shaped vessel thickening. This patient did not respond to eculizumab. And when we seeked for his genetics, we found out that indeed he has a homozygosity for DGKE that came from his consanguineous parents. He has a sister who does not have the disease, but it's very important to know that the father has proteinuria and hypertension despite having only one allele of this disease. So children that start TMA before 1 year of age, consanguineous parents, especially if they have high-grade proteinuria, we should think of DGKE. The importance of this is that there is no specific treatment. You should treat the hypertension, ACE inhibitors, BRA, and so far, but this is the disease that does not recur after transplantation, different from the complement genes that usually recur once you do a kidney transplant. In the infants presenting with TMA, especially in the ICU, it is very important to understand and to think that there may be a pneumococcal HUS. The pneumococcus produces sialic acid, a neuraminidase that cleaves the sialic acid and leads to agglutination of IgM. This can lead to a positive Coombs test. So usually you have a sick child with pneumonia or meningitis in which you can show the presence of the pneumococcus, all the findings of TMA, but 90% of patients have a positive Coombs test. When you see that, you should think of pneumococcal HUS. The treatment is supportive treatment. Usually it's very severe and the patients require dialysis, but nowadays with broad range antibiotics, the mortality decreased a lot. Washed blood packs and platelets, and you should avoid plasma unless the patient needs any procedure. Also, when there is a TMA presenting below 1 year of age, there is a rare disease that we need to think about because the treatment can be life-saving, and you can only think of it once you have seen it. This is the cobalamin C deficiency, which is the vitamin B12 metabolism defect, not deficiency, but a defect in the enzyme. Usually it presents under 1 year of age with a child that has TMA and also has some kind of neurologic development issues. This happens because there is a defect in the enzyme that converts homocysteine and methylmalonyl coenzyme A, and therefore these two substances are highly elevated in the blood and they are procoagulant. So you change to a procoagulant state and this can lead to the TMA. What is the treatment here? The treatment is intramuscular hydroxycobalamin 1 milligram every day together with folinic acid. This treatment can save the life of the kid. You can reverse TMA, you can improve neurologic defects. So it's very important to think cobalamin once you see a small child with TMA, failure to thrive or developmental delay in seizures, high red blood cell MCV. Also, some cases are diagnosed, and there is one case here in Brazil that was published that was resistant to eculizumab. And as I say, the treatment is IM hydroxycobalamin every day. This can change the whole future of this child. So think cobalamin also in this subset of patients. We have evaluated some patients with secondary TMA. Secondary TMA are more usually found in adults, drugs, pregnancy, transplant, infections, and so on. And what we found is that the positivity of genetics to complement proteins or genes is variable. When you have a patient with a secondary TMA due to malignant hypertension, there is a high chance that this patient has a positive genetic finding for AHUS. This also may happen as infection, since the infection may be the trigger of AHUS. Nevertheless, when you have drugs or autoimmune diseases, the chances of having a genetic defect there or a positive panel or finding is very smaller. This may have implications for the treatment. So I bring you to finalize this talk, I will bring you the story of a young patient who had an infection from the influenza virus and also presented with TMA. This was the day of arrival in the emergency room, and then he was immediately transferred to the ICU, and where he stayed for 12 days. We can see here anemia that was worsening, severe thrombocytopenia, a very elevated LDH. The upper normal limit here is 400, and his creatinine was also high. When he arrived in the ICU with the triad of kidney injury, anemia, and thrombocytopenia, they immediately thought TMA and started plasma exchange. 4 days in a row of plasma exchange, and we saw no improvement. Platelet went down, hemoglobin went down, creatinine didn't improve, he was oliguric. And then the physicians thought AHUS and started eculizumab. First infusion on day 4, second infusion 7 days later, and he was able to be discharged 12 days after admission. He remained with eculizumab. He had a huge improvement, and actually he went through a genetic panel which showed a pathogenic variant in C3 gene. So in this case, the influenza virus was actually the trigger for atypical HUS. And how did they suspect that? Because he did not answer to supportive care and to plasma exchange with a persistent TMA. So this is a concept for secondary causes of TMA. You may have a genetic background there, on top of which there is a precipitating factor that can be a drug, an infection, or so on. And the combination of these two factors may be higher than the individual threshold, and this patient will present with a TMA. This is also valid for other diseases that we have seen that mix genetic background with environmental disease. So this year we had the publication in Pediatric Nephrology of a review called Thrombotic Microangiopathy in Children. And what I want to share with you is almost a checklist when you have a patient with TMA. So first of all, identify the presence of TMA with the exams that can be collected to do that. Secondly, evaluate the degree of organ injury, and one should pay attention to a complete physical exam and not only lab exams or imaging, but also a neurological assessment. Kidney function, urinalysis, and so on. So all organs can be analyzed. And then as a third step, define the underlying cause that may be driven by some clinical aspects, as I told you, diarrhea, very low thrombocytopenia with normal kidney involvement, complement levels, infections. Think about pneumococcal HUS in children, test for pneumococcus, test for some viral infections as well. We have seen a patient here, 3-year-old with a very severe TMA. He underwent dialysis. Everything was negative, and then he came with a positive IgG COVID. He recovered completely, and his genetic test is negative. So in this case, it was not an AHUS triggered by COVID, but rather a TMA caused by COVID. And that's where the genetic background is very important. Collect homocysteine and vitamin B12. If you have a high homocysteine level with normal B12 level, you should think cobalamin and start immediate hydroxycobalamin. Also, genetic testing that may not be available to start treatment, but may be available for you to see if you should continue or not with treatment with complement blockade. And this is the wrap up that I want to bring to you. So once you have a patient with a thrombotic microangiopathy, rule out TTP as a rule of thumbs on the bedside, the plasmic score. Stack HUS, especially if there is history of ingestion of some contaminated food and bloody diarrhea. And then in between, you have a combo between atypical HUS and secondary causes. When you have a secondary cause of TMA, try to check if there is any evidence of complement involvement. And here is a portfolio of exams that we may have available to check complement involvement. If there is any evidence of complement involvement, especially low C3, consider early initiation of complement blockade. If you do not have, then treat the underlying condition and consider changing for complement inhibition once the patient does not answer to your basic supportive care. This is, I won't go into detail into this table, but this is a summary of the main causes of TMA in children that can run from STEC, which is the most common, to pneumococcal HUS, DGKE, which is very rare, but we have to think in children who are small, TMA, consanguineous parents, high proteinuria, cobalamin defect because it's very easy to treat and you can change the life of the kid. Complement mediated HUS or atypical HUS usually is the last diagnosis because you have to rule out all the others, and that's why sometimes it takes longer to treat these patients. And also TTP, the autoimmune TTP is much more prevalent in young girls, but we have to think, and I have seen 3 cases of congenital TTP, which happens in the first months, and usually it's a very, very severe disease. So having that said, I want to thank you, and I will be open to questions if anyone wants to email me, and I appreciate the invitation to lecture here at Clínica Alemana. Thank you.